fix this thing. Now, what do you all think? C, Charlie, that is correct. Simple renal cyst, nothing murder, right? That's right. Initial workup, autosomal dominant polycystic kidney disease. What do you think? Ultrasound. That's right, ultrasound. I mean, if you say initial study, any of those other things look like it could be an initial study for anything. Not really, right? So, ultrasound. Acer and ARB, that's right. Which one of those is one? Sartan. Low sartan. Yes.
That first question, is that the one where we learned the other day about certain age groups and having a certain amount of cysts, that's when it's something to be worried about?
Yeah. But in this one, in that first question, let me go back. It's just one simple renal
Yeah, so
cyst.
that's
Yeah.
what I was saying, like, what about age?
It doesn't matter. One simple renal cyst in any age group is not concerning. It's up to three, two in each kidney, and then more than that. So on any simple renal cyst, just put that in, doesn't matter, okay? Now if you get 3, 4, I mean, if you get to any number greater than 1, and you're like, I don't remember, look it up. But the takeaway, like the gross takeaway that I want is simple renal cyst is nothing to be concerned with, all right? So people tend to want to, okay, we'll follow this up, we'll get serial CT scans, you don't need to do any of that stuff, okay? Where were we? There we are. What do you think? Delta. Kidney stones. Nephrolithiasis. Kidney stones. Yep, that's very good. What's the other thing with MSK? What happens to their renal function? Preserved, yeah, yep. This looks like the same question, but it's not. Find the word. There it is, I heard it. So, what do we do? A. Yeah. A. Why urology? Why not nephrology? Scalpels, not calculators. Right? That's right. All right, good. Because what is that solid renal system until we figure out what it actually is? Fancy. I told you to write it down, and this thing was bad. Which one is it? Smoking. Smoking is bad. You didn't write it down before, write it down. Smoking, that's right. Everything else, maybe smoking is a big risk factor. So, two broad categories we talked about for renal vascular hypertension. What was the first one? Atherosclerotic disease, that's right. What was the second one? Fibromuscular dysplasia. So which one of these things can help you differentiate between those two? A. Presence or absence of hyperlipidemia. If the patient doesn't have hyperlipidemia, then they're really unlikely to have atherosclerotic disease, right? Remember we talked about that as a potential risk factor. Response to antihypertensive medication. Why is D incorrect? Let me explain. Because either way, the inflow tract to the kidney, the renal artery, is sclerosed. It's alternating. The blood flow to the kidney is reduced no matter which etiology is correct. So they're both going to be resistant to antihypertensive medications, right? So how do we make the difference? Other signs and symptoms, and then lab work like this. And then globally, what does this patient look like? They have risk factors for what? Cardiovascular disease. So really dependent on lipids, because that would make you go one way or the other. Or can help, I should say, help the most. Renal infarction and renal vein thrombosis. What did I say was two common differential diagnoses? Pyelo and kidney stones. What do both of those things have in common? Flank pain. There you go. Right? Fortunately for both of those things, we'll generally get a CT scan, and that will show us if we have one of these things. There you go, perfect. 'Cause otherwise, they look kind of the same, right? Then, what would predispose somebody, you think, maybe for renal vein thrombosis? Something that we've talked about. Huh? Smoking, yes. But what else? Let's go with the kidney disease. Nephrotic syndrome. Nephrotic syndrome has a hypoalbuminemia, right? So we don't have that serum albumin, we have thick blood, kidney, or we get vein or thrombosis in weird places. What about renal infarction? What would predispose somebody for that? Atrial fibrillation, right? We got a big clot, little piece breaks off, it finds its way into places, and one of those places is the kidney. All right? It's like a kidney stroke, right? Good. Any questions so far? Because here we are now together at the end of it all, which is chronic kidney disease. Okay? And I will tell you, you are going to, I hope, my hope is that you find this lecture to be very repetitive. There is not a whole lot of new stuff in here because we have already put this together over and over and over and over and over again in every other lecture, okay? So, let's just start. One, what is our primary concern as a primary care provider when it comes to chronic kidney disease? What's that? Maintaining, preventing chronic kidney disease, lengthening the life of the kidneys for every patient regardless of comorbidity, right? Now I will tell you, age-related GFR decline is coming for everybody in this room. It is a fact of life, but what our goal is as primary care providers is to see the evidence of it as early as possible and stabilize it for as long as we can, right? Okay? So, what do you guys think the labs are going to look like for a patient with chronic kidney disease? What do you think oh my God, GFR is going to look like? Yeah, it's going to be going down. What do you think BUN and creatinine are going to look like? They'll be going up, okay? What about proteinuria? Yes or no? Probably, right? Yeah, okay? And that's really it. Even chronic renal disease, unless it's really, really severe or significantly acute, like the acute renal illnesses are fine, but we're talking chronic, still doesn't walk in overtly with many symptoms that you will see and identify uniquely as this is a kidney problem. This patient has chronic kidney disease, right? Unless that patient has some history. Otherwise, if it's just normal age-related decline, this patient has been taking care of themselves, they're healthy, they're active, they have a big diet, they don't smoke. What are we going to see? How are we going to find chronic kidney disease, even pretty severe chronic kidney disease? Incidentally, really. Or, more specifically, by paying close attention, right? By not waiting until it is over, right? Looking and seeing this patient's labs and identifying a pattern, okay? So everything on here, up to a couple of things about urea syndrome, are going to seem very, very, very repetitive. And that is for a reason, okay? Because we're going to talk globally about chronic kidney disease. You could do a whole lecture, you can do all of these blocks on chronic kidney disease alone. We're not going to do that because we don't have time. So we're going to talk globally. Takeaway is what I've already said. 1, find it early. 2, keep the kidneys alive for as long as possible. And then the third one would be make appropriate referrals. And we'll talk about how to go about that. So again, I've mentioned these folks in the past. They're the ones who create this clinical practice guidelines. In the United States, you can also look at the National Kidney Foundation. The American Society of Nephrologists really defers that to make clinical practice guidelines. So if you're, oh my God, I'm seeing a patient that has this weird thing, he's peeing blood and he was just sick. I don't know what the hell that guy said, but it sounds weird. You look it up, IgA nephropathy, what am I supposed to do? That's what a clinical practice guideline is for, all right? So these are the established international ones. The CKD guideline, it seems pretty old, and it is. 2012 is pretty old. But the first one, I mean, they're just in the initial collection of data. So I would not expect to see this CKD guideline probably 2026, maybe 2027 is probably a realistic estimate. Because establishing worldwide clinical practice guidelines takes a while, as you can probably imagine. So just understand it's under revision. But But you go and you look at like 2012, that's it, that's the one, okay? So this is important, okay? Alterations of structure or function for 3 months, okay? What does that mean? What does that mean? What does that mean? It's on the next slide, but what do you think it means? Structure or function? What do you think? Lab abnormalities, there you go. Like for example, GFR reductions, persistent. BUN and creatinine elevations, persistent. Proteinuria, hematuria, persistent. What about structure? How would we identify the structure? How would we, like if there's only a way we could see what the kidneys look like, what would that be? Ultrasound, like ultrasound abnormalities, right? Identification of either bilaterally shrunk kidneys or asymmetry in the kidneys, right? Established for greater than 3 months. That defines chronic kidney disease, and that is exactly what this is. Now, you might find it weird that albuminuria, hematuria, sediment abnormalities are in structure, but based on KidGo's definitions, ultimately what it means is that is an assumed glomerular malfunction, dysfunction, abnormality of structure of the glomerulus, a micro structure. Does that make sense? Okay? Versus the more grossly obvious shrunken organ itself, okay? And then other things, abnormalities by biopsy or imaging, history of renal transplantation. Hopefully you guys can put that together. Hey, have you ever had surgery? Yeah, I had my kidneys changed out. Oh, shit, all right, you know what I mean? Put that together. And then GFR, established below 60. This is our threshold. GFR less than 60 defines chronic kidney disease. Okay? That is an important number too. Like, there's not a whole lot of numbers you need to commit to memory. That's one of them. Because it's just important for you to be able to see that and recognize what it is without having to look up every single thing. Now, is it going to say, how are you going to establish? You're going to see that it's low, and you're going to see normal. But that's well below normal. And then you remember the lower end of threshold of normal for GFR? 90, right? So that's weird. So we're 30, right? We've already lost another 30%. That's a lot, okay? So it's important that if you see that, you understand what it means. And what does that really mean? That's kind of our consult threshold or referral threshold, right? Probably sooner, but at that point, that patient needs to be on a nephrology service, at least to be seen and identified and evaluated, all right? Now, again, another redundant slide. GFR, albuminuria, proteinuria, urine sediment abnormalities. We've talked about this over and over, right? Structural abnormalities or medical history. Now, what in their medical history do you think would help us identify this patient as at risk for CKD? Give me some things. Diabetes. What else? Hypertension. What else? Smoking. Sure. What about some other things we've talked about? Heart disease, polycystic kidney disease, IgA nephropathy, right? Any of some of these more acute illnesses that we've had that convert into more of a chronic state, right? Any of that stuff predisposes this patient to an earlier onset of chronic kidney disease. And what does that mean for a primary care provider? That we need to be paying closer attention to their labs, and if they're not already on a medication, they should be. And what medication am I talking about? An ACE or an ARB. Okay? Now, this is not important. Oh, I take it back. This is important. But this is not important for you to remember. What is the important takeaway is that there's two different things that defines this patient. Now, have you guys all talked about chronic kidney disease in general? I bet other classes have mentioned that stage 1, stage 2, stage 5, right? Stage, like, that's kind of a nomenclature error because that's not really the case. What's really the case is we define this patient's chronic kidney disease by GFR reduction and level of albuminuria, okay? So it's just important that you know that fact, not that you memorize these stages. The most important thing, and if you look at this, you're like, well, what in the hell? We're already at stage 3B before I need to make a referral, right? Because 60 is the bottom end of stage 2. Well, that depends on the patient in front of you. I'll tell you that the threshold for absolute referral is at 60. You have a patient that has mildly decreased and they're in that stage, that's a clinical decision-making process for you when you're out there practicing. I just want to call that attention to that because they get asked questions about that all the time. right? So we have this patient who's in stage 2 kidney disease. We're not gonna do anything with him? Not necessarily, no, okay? But just know that the answer about when to make the referral, if they haven't already been, is at 60. Does that make sense? So the bottom end is stage 2. And which one of these things do you think is worse? Which one's worse? Which one is sad, right? Albumin, yes. Albumin is worse. It is a greater predictor of adverse outcomes and morbidity and mortality than even the GFR decline. At a given GFR, side by side, the patient who is spilling more protein has a worse prognosis. Okay? This is something that you don't also have to memorize, but if I were you, and I'm not, but if I was, I would print this out and put this on my wall in whatever place you see patients. Okay? Because this is something that you should need to know. You should be able to identify this patient has established proteinuria, they have a GFR reduction, you hit the Pokemon chart, and you see what color it is, and then you decide what do I need to do from there. Okay? This is something that you shouldn't commit to memory. Committing things like this to memory is a waste of brain capacity. But understanding that it exists and knowing when to reference it is not. Okay, yes?
Anything in the yellow, I assume you just refer.
Well, it really depends, okay? Yes. I mean, obviously the red, the yellow, I would say, me? Yeah, I would. You know what I mean? But again, it depends on the patient, right? You might have somebody that has comorbidities that may be still kind of in the green, but you might want to pump. But if you want the bottom line to upgrade, like the bluff, yeah. Anything yellow or definitely orange, gotta go. You know what I mean? So just understand, you have to quantify, you have to understand their GFR decline, and you have to see what you got to do with this patient. All right? So this is something that would be useful, right? You go to any provider's office, and you've probably been in several, I'm sure everybody here shadowed, they got all kinds of shit tacked to their walls, right? Because we can't remember this stuff. All right? So, again, here's another redundancy. Oh, by the way, where do you find that thing I just had? That's in the KDIGO guidelines. Okay? You can just go there, print it off, or you can just print it off from the slides, because you have it, it's right there. All right? You're welcome. CKD, independent risk factor for cardiovascular disease, right? Whoever mentioned cardiorenal syndrome, you're exactly correct. They're going to antagonize each other until one of them goes. All right? And then proteinuric CKD, highest risk. What do I keep saying? Over and over again. What do you do about proteinuria? Figure it out. Right? Figure it out. And this is the takeaway. This is the bullet about why it's so important for us. Because not only are we protecting the kidneys when we intervene early, we're protecting the heart. And the heart is the thing that's going to kill this patient. All right? So, there you go. Of everything we've talked about, this being the bulk of the class, this is going to be the reason you see most of your chronic kidney disease. Diabetes and hypertension. Things you learned in other classes. Right? Sorry. It's true. All right? I mean, because how, the prevalence, right? The prevalence. Anybody in here seen patients before? Anybody in here seen a hypertensive patient before? Yeah, they're everywhere, okay? Anybody in here have a diabetic relative? They're also everywhere, okay? How much glomerulonephritis is running around up there? Not much, you see what I mean? Common things are common. You're gonna see kidneys being shut down for diabetes and hypertension. And why does it happen? Like, why do you think kidneys get shut down by diabetes and hypertension? Because people miss the forest for the trees, and they pay attention to the diabetes and the hypertension, and they don't pay attention to the kidneys, which is ultimately what's going to take the heart and put it under strain, and then the heart's going to kill the kidney. You see what I'm saying? You miss the big picture. You pay attention to the focus thing. You pay attention, you know, you see the broken bone and not the bleeding, right? Or what's going to kill that patient. You see what I mean? That kind of stuff. That's why these things are still so tragically morbid and mortal, is because we don't do correctly, and you will see it. You guys are going to see it when you go out to see patients. You're going to see it in phase 2. You're going to notice the blood pressure, and you're like, how long have you had this blood pressure? And then you're going to look in their historical vital signs, and it's going to have been forever. And you're going to say, Did anybody ever talk to you about your blood pressure? Like, no. And you're going, what the? You know what I mean? So don't be that guy or gal. Don't be that person. Don't be that provider. Pay attention, all right? Even if you don't have time to pay attention to it that day, remark on it, tell the patient, I want to see you back, and we'll see what's going on with his blood pressure. You know what I mean? Sometimes you can't take care of everything every day, but don't let it walk out the door. What is this slide? Everything we've already talked about. These are all the topics we've discussed in this class. Okay? So why is this slide in here? Because look how much stuff we've done, you guys. This is something that we've already discussed as well. Okay? Diabetic and hypertensive nephropathy, general onset of chronic kidney disease. You have destruction of nephrons by atrophy and fibrosis because of overwork, whether it be because of hypertension or diabetes in general. The remaining nephrons get bigger and have to work harder. And then what happens? They scar down. And then now we have even fewer nephrons who have to work harder and so on and so forth. And this thing becomes a vicious cycle. All right? This is from the book. This explains all of those things, right? Hemodynamic versus non-hemodynamic, direct nephrotoxicity, fibrosis, increased cytokines and fibrotic factors on the hemodynamic side, systemic hypertension because of an on-RAS system. Then that leads to a cardiorenal syndrome, which leads to an even less perfused kidney, and so on and so forth. And I made this because I think it's easier. And I know that I could make it a circle and fix the lines, but I don't want to because I like this one. All right? This is generally what happens, and it just goes in the circular pattern until RIP, right? So we intervene to try to break this cycle or slow it down. Really, we're not breaking the cycle. What we're doing is slowing down the vicious circle. We're slowing down the spiraling towards the drain. You know what I mean? Okay? And again, this is these two things kind of go together. Early onset stage 2 kidney disease, patient's going to walk, talk, look, act, be normal. They're going to be fine. They're not going to be sick at all. They're just going to have some lab abnormalities that we have to pay attention to. They're not going to be overtly ill based just on the kidney alone until they get to almost no glomerular filtration rate. Like, the kidney's almost non-functional by the time they come in. You're like, holy shit, this is uremic syndrome. Okay? Any questions so far? It's pretty straightforward. It's pretty redundant so far. Like, nothing new really so far, right? Okay. So, signs of uremia are remarkably similar to signs of cirrhosis. Okay? Both filtration mechanisms broken, right? So, uremic stuff looks a lot like cirrhotic stuff. And we're going to kind of walk through these system by system very briefly, all right, just to highlight a few of the more, common symptoms. But it should fit, nothing on this. If I just asked you, describe what you think a patient with end-stage renal disease, like complete renal failure, would look like, you guys could put this together, all right? This is from Netter. So what are we going to find? Chronic findings, right? We're talking about general chronic findings. Hypertension. This is the most common one. Hypertension is the most common one. And diagnosis, right? What are we looking at? We're looking at their history, right? And how do we establish, remember we going back, we said those 3 months. What if a patient's new to your service? How would you establish chronicity? You think? Ask them. There's one way to go. Medical record, yes, exactly. You go back and you just put the story together. If you have it. Now, it's not always that simple, okay? But failing that, right? Let's say you have nothing. How can you establish chronicity? Follow them for 3 months, okay? Honestly. And then you see this. Looking at the history, basically, hypertension, diabetes, anything that predisposes that patient to a chronic kidney disease. Physical exam, we're going to talk about that as we're moving forward. All right, so This is just a, general physical exam. But also, we're gonna show some things that kind of stand out as far as system by system go. Anything on this laboratory finding list that is unfamiliar or doesn't make any sense, based on everything that we've discussed up to this point. And I mean that. Is there anything on this list that doesn't make any sense? Why is that on the list for chronic kidney disease? Right? That's why I dance around and harp on the lab so much, so that by the time you get here, you understand. This is what it is, right? Anemia. What kind of anemia? Anemia of chronic kidney disease. Does that sound familiar? So, yeah. Okay. Increased A1C, right? Everything's off. Like this patient's glycemic control is shot. Metabolic acidosis. Why? Lactate. High anion gap metabolic acidosis, right? It's on the mud pile's gold mark thing. Hyperphosphatemia. I know I brushed by phosphate real fast, but I said the most common cause of phosphate disturbances is chronic kidney disease, right? Hyperkalemia. Hypocalcemia. Everything's going. Everything's off. Okay? And back to this. This is the threshold. Right? And it says often earlier. So again, it just depends on the patient. When you have a threshold that's an absolute threshold, do you have to wait till the patient gets there? No. You have to make a clinical decision based on the person in front of you. Right? Does that mean that when a person walks in and they have 89, you have to punt them over to nephrology? No. But you know what I'm saying. You don't have to wait till this person gets to 60. If you see somebody and they have risk factors, and you're like, this person just isn't doing great, send them over. That's what subspecialists are for. All right? That's what subspecialists are for. And most of the time they'd rather see them when kidney function is more preserved, because we can all do more good before the damage is done. You know what I mean? So, this is that same physiology about why creatinine remains relatively stable until it's intrinsic renal disease. Okay, the same thing we've talked about. Why the creatinine is now going up. So don't pay attention just to serum creatinine. Really pay attention closely to both numbers and pay attention to the GFR. All right, and then, of course, any albumin that's being spilled. This is just a roll-up of everything we're going to start to talk about now. But cystatin C, do you guys remember me talking about that? Okay, so the guideline, the CPG, is once you have a patient that has a persistent reduction in GFR, you want to get a cystatin C to confirm it. And you guys remember why I said cystatin C is more precise than GFR?
It's not variable.
It's not variable. Yeah, it's not affected by so many biological parameters like creatinine is. So person next to person next to person is going to tell you yes, chronic kidney disease, or no, right? Whereas GFR is different if you have like a healthy young adult next to an older person who has maybe more muscular atrophy. Okay, so yeah, can use right now predominantly as a confirmatory test. Can you order it? Yes, you can. Okay, all right. It's good to have that data. Again, it's good to have all that data with the patient when they go to the subspecialist versus getting to the subspecialist and then them having to order this data, right? You know what I mean? So just good to have the studies if you can get them. So estimation, you can do other the calculation when you get a cystatin C, it gives you an eGFR based on the cystatin C. It should be similar to the eGFR that's estimated. If it's not, that may mean one or the other is off. Could be a creatinine problem. So anyway, there's ways to figure that out. The point is just get that as a confirmatory test. And then I did tell you, you can directly measure glomerular filtration rate. You being not you or us, you being the nephrologist can directly measure it. And sometimes if it's going to impact treatment decisions, meaning that if this patient needs it for whatever reason, they can get a direct measurement of it. But it's a more invasive thing. And so in general, our purposes, get the GFR, get the cystatin C, and then at that point, that should be sufficient and refer on to the nephrologist, okay? Does that make sense? And these are just sort of like the thresholds of where we're going to start to see things. But again, first manifestation, early manifestation, or the patient's not, they're going to start to develop hypertension, okay? And then as we get worse and worse and worse, but you see where uremic syndrome shows up finally, right? Their GFR's in the toilet, okay? Imaging, two different things we might see, right? The one we've been discussing here, chronic kidney disease, because of reduction in nephron mass, so what are we expecting? Small kidneys, raisins, right? Talked yesterday about a reason why we might see huge horse kidneys, AD, DKD, significantly less likely. But, again, if we're working it up and we get the ultrasound result, it's going to show us. And remember that the ultrasound result is a confirmation of chronic kidney disease, alteration of structure, right? So, okay, the heart is going to win, and the patient's going to lose, right? So the heart's going to die first, is what I mean. Okay. So maybe I should have the gun pointing the other way. Who knows? Anyway, it's a standoff, right? And generally, in the vast majority of the cases, I mean, I guess if the person dies, the kidney dies too, so technically the heart still wins. I guess if that's what you want to go. But yeah, that's what's going to kill this patient. And that's ultimately, really, renal protection is trying to affect constitutionally, it's going to protect the heart. So, are we protecting the kidneys? Yes, but by doing that, we are undoing or slowing down damage, right? Any questions so far? It's all still pretty straightforward, pretty stuff we've heard before, right? So, CKD, what does it do, right? If the RAS system is chronically on, what does that do to the heart? Huh? It makes it work like harder against higher resistance. It's like going to the gym, right? The heart then hypertrophies. Which part of the heart hypertrophies? The left ventricle hypertrophies. And what does it grow? Does it grow out or does it grow in? It grows in. What does that do to stroke volume? It takes it down. So that means less blood is coming out. What does that do to the kidneys? Zips them up and turns the RAS up higher. What does that do? That's a vicious cycle. That is cardiorenal syndrome. Okay? Does that make sense? All right. And then let's take the bottom. We've got anemia of chronic kidney disease. What does that do to the heart? Makes it work harder. See what I mean? We have increased workload, decreased stroke volume because of remodeling, and we just keep going. Okay? That's what it is. And here's the takeaway, right? If nothing else sticks about cardiorenal syndrome. If the patient has heart disease, find their kidney disease, and if they have kidney disease, find their heart disease. Because they have it. Okay? Here's a picture of cardiorenal syndrome. Here's one with circles. All right. Any questions so far? Okay. So I said one of the most common reasons for phosphate accumulation is reduced clearance because of chronic kidney disease. What's the relationship between phosphate and calcium? They antagonize one another, right? So hyperphosphatemia would do what to calcium? Kind of drive it down, right? And what happens in response to a low serum circulating calcium? What gets turned on? Parathyroid hormone. And then what does that do? Eats the bones to kick out more serum calcium. What that is high dynamic turnover, bone turnover. You end up with lytic lesions all over the place. That's renal osteodystrophy. Because of chronic kidney disease, we're talking about now into the really severe reductions in GFR. All right? Adynamic. And then over the course of time, when there's not much more calcium left, it can turn into adynamic bone disease, which means the remodeling isn't occurring anymore, so we're not building up bones. So what do you think this patient might be at risk for? What kind of fractures? Pathologic fractures, yeah, pathologic fractures. As a matter of fact, a lot of the radiographs kind of look like plasma cell myeloma, like little rat-bitten lesions, like little punch-out lesions. Okay. You want to know the cause of it? Osteitis fibrosis cystica. Isn't that fun? Okay. So that's the mechanism we just discussed. All right. So just understand alterations of phosphorus, alterations of calcium, alterations of the activation of vitamin D, which is another function of the kidney. And so it ultimately leads to lytic lesions, high dynamic bone turnover, high turnover disease, ultimately becoming low turnover disease, and the patient gets sicker and sicker. You kind of, I don't know how well you can see this, but these just like little punch out, like osteitis fibrosis cystica, so fibrotic cyst, right? So kind of looks like a cyst, would look like an ultrasound, right? Just a fluid-filled cavity, except this is just air, just pumped out. Yes?
The renal osteodystrophy and the osteitis fibrosis cystica, is that two names?
They're the same thing. Two names for the same thing.
Okay.
Yeah. If you guys are looking at this slide, should be the part that stands out. It's not your job, really. Okay. This is somebody that we were talking about somebody who's on the nutrition service. They're managing ins and outs very acutely. This is somebody who needs to have phosphorus binders. Okay, so this is not a primary care issue. Just understand that. Take away. You want to have the literal bottom line up front. Control of hypophosphatemia. How do we do that? We don't do that. They do that. Who's they? Other people. Okay? Fair enough? You're picking up what I'm putting down here? Okay. Hematologic complications. Now, let's talk about hematology, because we have that on Tuesday. So, unless it snows. I don't know. Let's see what happens. All right. So, normocytic, normochromic. All right? Impairs GI absorption and mobilization of iron from body source, resulting in a functional iron deficiency. And then the big red Y. What's the Y, you guys? Huh? Hepcidin, that's right. Does he say hepcidin?
Yes.
Whatever, I
Yes.
say hepcidin, so what I say is my class right now. Hepcidin, right? So what does hepcidin do? It closes the iron door, right? We like that, don't we? It closes ferroportin, and it keeps iron locked in the cell so that it can't return to the macrophage compartment. It can't go back to the spleen. It can't go back to where homeostasis takes, or hematopoiesis takes place, which is where, generally? The bone marrow, right? So, we have an upregulation of hepcidin. Why, in the case of chronic kidney disease, would we have that, you think? Sure. Even a one-word answer, but that's right. What? Inflammation. Yeah, one word, inflammation, right? Yeah, systemic inflammation, kind of the same with like the rheumatologic disorders and so on and so forth, other reasons why you have anemia of inflammation. This one's chronic kidney disease, so you're absolutely correct. We have a confounding picture here, because what else isn't, is it on here? What else isn't the kidney doing that would present with an anemia anymore? It's not making EPO anymore, okay? So we have a double-edged anemia, if you will. But both chronic disease, both going to start out initially normocytic, normochromic, and then ultimately becoming microcytic, right? All right? Yeah. So yeah, that's our friend. This is why, this little Danny. Hepcidin. All right, coagulopathy. Can you withstand a reason? Like everything's kind of off now. Coagulopathy it's very similar to coagulopathy of liver disease, right? Platelet dysfunction. So what does platelet-like bleeding look like? What does platelet bleeding look like? Oozing, bruising, gingival bleeding, yeah, right? Generally. Hyperkalemia. Okay. Not able to get rid of it, right? Acid-base disorders, which one? Hagma, which then contributes more to hyperkalemia, right? Probably, yeah. Right, not new stuff. Neurologic complications. Remember hepatic encephalopathy? Treat with lactulose, right? You get the ammonia out of their brain. In this case, different thing. More proteinaceous waste, right? Azotemia, uremia now, accumulations. So we have hepatic encephalopathy. What do you think it would look like? It would look like this bullet that says symptoms. Difficulty concentrating, leading to stupor, coma, right? So this patient is untunded, right? So you have a patient with chronic renal disease, established, we know that. Now they're losing, mental status changes. What does that say? They're probably not clearing. This patient might need to go off to dialysis, or it might be time for renal replacement therapy, okay? Endocrine complications stand to reason, right? Hypoglycemia, like alterations of their ability to utilize ADH, glycemic control, all completely gone. Gonadal axis, hypothalamic pituitary axis destroyed, right? End stage disease. All right, any questions? No? I have a question. We have 9 minutes before break, but the rest of this should go by pretty quickly. And then you guys can get Monica to come in early, Dr. Katzenberg can come in early. Is that what you want to do? All right, well, we're going to do it. Primary, and if you have to go to the bathroom, just go, okay? Just go to the bathroom. You big boys and girls can go to the bathroom if you have to. Primary care approach to CKD, okay? And look at it. History, physical exam. Don't give them anything that's going to shut down their kidney. Okay, really. That's what it is. But I can't stress that enough. If you have real severe kidney disease and you don't know, your clinical pharmacologist is going to be your friend. All right? Call them. That's what they're there for. They love it. Nobody ever calls them. All right? And say, hey, I have this patient with stage whatever, GFR at this. They're on these 17 different meds. Sometimes they'll see them for you. All right? Oftentimes they will. They will see them. They will interact with the patient. And they will go over medication interactions, and they will discuss in depth with that patient potential contraindications and indications and side effects. Okay? Because what's happening if we have reduced renal clearance? We're increasing the serum concentration of any given drug, and that might lead to an antagonistic or synergistic effect or something else. Or antagonistic effect, right? Something might not be working the way it's supposed to. So again, we have to be really careful with those things, because the things that are filtering are broken. The filters are broken. So we have to really be careful with what we give this patient, even very innocuous seeming drugs. All right? So, differentiate AKI from CKD. You don't have to, listen you guys, you don't have to go down and memorize you don't have to go down and memorize these charts. This is just a general primary care approach, okay? So I'm not going to ask you, what's step 3 of the organizational chart that I showed you in blue and purple? Now that was in purple, you guys got it wrong. No, I'm not going to do that, okay? I'm going broad strokes here. Broad strokes, I'm just giving you guys the overview. Differentiate AKI from CKD. What does that mean? Acute versus chronic. Literally, yes. Is this patient's reduction in GFR an acute process that we haven't recognized, like maybe an IgA nephropathy or post-streptococcal, something else? Is something else going on with this patient? Or is this chronic kidney disease? And how would we establish that? Chronicity, exactly. Go back in this patient's medical records. Do a history, right? Medical history, surgical history, right? That's it. Understand. And then also, not only just is it acute or chronic, if it's chronic, is this a de novo, right? Is this a new acute kidney injury in a patient who has chronic disease? Or is this an entirely new thing at all from a patient who has otherwise healthy kidneys? All of this stuff that we've already talked about. And it all boils down to history, physical exam, labs, and looking at the patient's own labs. Does that make sense? Like it's not, this is not rocket surgery, this part of it. Okay? Patient education, therapeutic lifestyle changes, daily and dietary interventions. Can't be afraid to use our friends and the nutritionist here sometimes, right? We might need to monitor this patient's ins and outs. Maybe this patient is taking too much exogenous calcium in their diet. They need to talk. Maybe they have too much protein ingestion, because exogenous protein can actually affect an increase in proteinuria. So maybe this patient needs to have an education about reduction in their animal protein intake. We use our subspecialists. Do not be afraid to call nutrition and send this patient on for a consultation if you need it. Okay? Vaccinations, right? This is all simple, straightforward stuff. These patients are sick. And so we need to make sure that we are proactive in their health care. All right? Okay? Anything on this confusing? CKD patients are at increased risk of other things. Give them vaccinations. Manage their comorbidities. Because ultimately, if they have comorbidities, right? Is the renal disease the cause of them or the outcome of them? A symptom of them? Oftentimes it's a symptom of them, right? If they're diabetic, their renal disease is a symptom of their diabetes. If we can manage their diabetes, then we can get their kidney disease sort of under control, right? That's what we've been talking about. The whole thesis of finding microalbuminuria when it first starts. See what I mean? Manage comorbidities. It's not new at all. Same thing in every class. Encourage a healthy diet. What does that mean? I'll tell you what that means. It means you encourage a healthy diet and then you make them go talk to the nutrition nerds. Okay? Yeah? For them to ignore them. But at least you did it, right? At least you have a referral in there, like, right? You can only, it's a whole, you can lead a horse to water, right? You can present this patient with all the options in the world. And I got what you've already talked about. Therapeutic lifestyle changes are going to be the hardest thing to do. But the more, the more people who are running up and punching them in the back of the head, tell them, hey, stupid, you're going to die, the more likely they are to listen. You know what I mean? Okay? Blood pressure control. Oh, there's our friend again. Right? But this is the one. Titrate to maximum dose, right? Maximum tolerated dose. You want to pump them full of this stuff. And why? Reduce glomerular perfusion pressure. Reduce proteinuria. Keep the kidneys from being, remember, because one of the other mechanisms here is glomerular hypertension, so we want to try to maintain that, right? And as we're doing that, it's also going to help the heart. It's got like the ACE and ARBs are going to be renal protective, cardio protective. They're just good drugs, okay? So anyway, don't forget about keeping an eye on the patient's potassium and at the initial part, right? Because we can initiate or precipitate hyperkalemia, especially if we're starting, we're getting this patient, we're inheriting them at later stage kidney disease, then it becomes increased risk. Like likelihood at the beginning, low, okay, low. But as we titrate up, we want to keep an eye on their potassium. That's the big takeaway, all right? SGLT2Is, you guys remember those? Okay, they are FDA approved for chronic kidney disease. Okay, so that's good. I mean, that I would be surprised if that's not standard of care when the new guidelines come out to just be our direct to an SGLT2I. All right. Apparently they do everything. You know what I mean? So, but they're great drugs, and they're also cardioprotective and renal protective, help glycemic control, as you know. So. Demonstrated effect on mortality. So the science is bearing out that these patients should be on these drugs. And again, that's why they're FDA approved. Okay? Second line, we're going to start with ACE and ARB, but likely that's going to be part of the drug combo these patients will be on. Lipids, right? As necessary, manage their lipids. Keep an eye on their heart. Like nothing specifically new here. Like this is all stuff you already know. Lipid lowering therapy, cardiac disease, right? This patient is going to have cardiac disease because they have renal disease. Okay. This is just visual illustrations, right? We have a normal decreasing, and then all of a sudden, as the GFR goes down, our risk of heart problems goes way up, right? That's a heart, in case you need heart. Okay. Here now there's an arrow through it, like by 1 times a day. So that's a heart, and sad, right? More is not better in this case. Right? Higher risk. As the GFR goes down, the risk of cardiovascular outcome goes way up, double, right? Same thing here. If you look, any cardiovascular disease, if you look at a normal, we have about a doubling as we get to severe and end-stage renal disease. Right? It's just visual representation of what I've been saying over and over again. You guys get the message? Okay, good. Medication adjustments, all right? Again, same thing I just said. I told you this is going to be a redundant end to the course. Be careful, whenever you prescribe this medicine. What do you think? Do you think this patient's going to be on one med that you prescribe them and that's it? They can be on 1,000 things, okay? So be careful of everything that you give them. And make renal dose adjustments as necessary. Which, what does that mean? That means you actually have to read that big stupid thing that comes in the medicine, right? Or go on to Dynamed and see what the right thing to do is. Lexicon, okay? Cautionary medications. Don't even look at this list, okay? Don't even try to study this for the test. This is not even close to anything that would be considered comprehensive. It's just a list of common ones they have to be careful with. But don't study this list because I'm not going to ask you something off of this chart. It just doesn't make any sense. Take this away with you in clinic, okay? Use your consultants.
Sir?
Yes.
Sorry. So going back to the cardiovascular disease, talk about antiplatelet agents.
Mm-hmm.
Are you just gonna go ahead and stick all these people on aspirin, or is it kind of a case by case basis?
It's a case-by-case basis, but most of the time they'll probably be on aspirin. Because we have the other problem, like depending on where they are, they may have this platelet aggregation problem, so Plavix or aspirin might do them some good. It just depends on the patient in front of you. But it's still, for purely cardiac reasons, yeah, probably not so much anymore for everybody, but for these patients, I think it's just, and even the risk of it being a stereotypical NSAID as outweighed by the potential antiplatelet antithrombotic effect. So I would still, yeah. But yes, if I had to answer your question more succinctly than that, it is a case-by-case basis, yeah. Referral to nephrology, right? So what is this? This is that Pokemon chart that I said in a pyramid, right? So green is good, red is bad, all right? That's why I said, print that thing out, put it on your desk, look at it. Ask your medics questions from it, pimp them. They won't know that you don't know. They'll think that you know, and then you'll sound smart, okay? End-stage renal disease, okay? What did I decide? What do we define end-stage renal disease? Anybody remember that? The need for renal replacement therapy. Okay, the need for renal replacement therapy. Okay, end-stage renal disease. GFR less than 60 defines chronic kidney disease. This is the end of that, okay? So, this GFR here is going to be less than 5 to 10. But what's normal? 90. This patient has nothing left, okay? Nothing left, all right? These are important. Right? These are absolute indications for referral urgently for dialysis, right? Uremic syndrome symptoms, uremic encephalopathy, uremic pericarditis, which I think I skipped over. You may very well hear a pericardial friction rub from this patient, not because of inflammation, but because of deposition of waste products around on the pericardium, okay? That means this patient systemically needs to be cleared. Their kidneys aren't going to clear anymore, so we need to clean the blood and put good blood back in. So these are absolute contraindications, or indications, pardon me, to send this patient for dialysis, all right? And it should make sense. All of these things are things the kidneys are supposed to do. Manage fluid electrolytes, manage hyperkalemia, get rid of waste products, manage acid base, right? End-stage renal disease. Does that make sense to everybody? Barely hanging on. Okay, I'm gonna go through this quickly. Like I said, we're almost done. But I just wanna show you guys, again, everything from here, renal replacement therapy. I'm not gonna ask you about different types of dialysis. I just wanna introduce you to them. So we're gonna kind of go through it, but understand that RRT means either dialysis of some type or literally kidney transplant, okay? So we have renal replacement. These are hemodialysis. You guys are familiar with like the Phrenesis Kidney Care Centers around town, things like that. Those are dialysis centers. Patients go in however many times per week or once every week. They go, they sit, they watch Matlock, and they have their blood group cleaned out, okay? And it takes a long time. I mean, you see what I mean? Sometimes up to 3 sessions a week, 3 to 5 hours. This is a full-time job, getting your kidney replacement, okay? Obviously, with a patient who's already ill, with a patient who doesn't have a very good immune system, it's invasive, you know, venipuncture, potential for infections, right? Potential for all kinds of things. A little bit better than that is peritoneal dialysis. So the peritoneal membrane actually becomes a dialysate membrane. So blood is filtered across the peritoneal membrane. And as you see this lady, she's reading TV Guide. And up there is a clean bag of dialysis fluid. And down there is a big bag of pee. That's what it is, okay? So you can do this at home overnight. It's a little bit more convenient for patients, but again, they have to be a little bit more stable, a little bit better health. They also have a permanent catheter placed, so we have a big risk of infection for these patients because you have an indwelling catheter, okay? Kidney transplant, decent survival rate, right? Not bad. Anybody know what one of the big transplant centers in the country is? UNMC, lead transplant center in Omaha. ESRD, again, does it make inherent sense that when you get to end-stage renal disease that morbidity and mortality go up quite a bit? Yeah. Because once the kidneys are at this point to shut down, so is the heart, so is the liver, so is the person, okay? So end-stage renal disease, lengthening life as much as possible, but not super great. And again, is this point clear enough at this point? Even now, at end-stage renal disease, when their kidneys are still just barely hanging on, the heart is what's still going to go first, most likely. Okay? Most patients with chronic kidney disease are going to go from a heart-related condition before they get here. But even when they get here, it's still the heart that's probably going to take them out. Okay? All right. Bottom line, treat comorbidities, refer to nephrology. Don't give them anything that's going to kill their kidneys. Treat complications, right? If they develop an acute kidney injury, if they develop uremic syndrome, treat those complications, all right? And use your clinical pharmacologist. Here's this thing again. It's important. Okay, print it out. The kidney and aging, you want me to sum this slide up? Here it goes. Your kidneys get worse as you get older. So you as a person, as a patient, do everything you can to maintain your own kidney life and duration. Avoid nephrotoxins. Don't take Motrin every day if you don't have to. All right? And that's it. Any questions? Now, was what I said true, right? There wasn't a whole great deal of new information presented in that slide deck, right? It was a lot of the same conversation that we've been having over and over again. So I hope that puts a little bit of a button on it. I know you guys probably haven't even started looking at this stuff yet, even though I told you not to. But anyway, so quizzes. I have 3 practice quizzes that'll open up Monday or Tuesday noon. So you can take those as many times as you want. They're on Canvas. Slide deck for review, I'll upload it before our review, and then the review we'll do at noon on Tuesday after hematology oncology. Unless there's any questions, that's all I got. And I don't think I see you guys after the test until for like 3 weeks or some shit before we start urology. But anyway, if you have any questions, let me know. As you start to look at this stuff, you have my contact information. Use it if you need it. And other than that, I wish you would be studying for hematology and oncology.
Yeah, I got in touch with Dr. Casimir.